Morning, everyone. We have already discussed in the last class about the laser characteristic, different types of lasers, and the uses, advantages, and disadvantages of laser, and how laser is being produced in a laser machine, and how this laser is carried to the surgical site. Everything has been discussed in the last class, and in this class, we are dealing with the applications of diode laser as well as RBM lasers in implantology. The application of laser in implant dentistry is mainly include implant site decontamination, that means sterilization and socket preservation. It can be used in sterilization as well as in socket preservation. And second stage implant recovery or second stage implant surgery. A third, management of peri-implantitis. In peri-implantitis, it is mainly used in debridement as well as sterilization areas. Fourth one is implant osteotomy, which can be done only with RBM lasers. And last one is low level laser therapy. It's an adjunct to the implant surgeries, which promote healing of the wound as well as it promote the osseointegration process. So in short, application of the laser in implant industry include implant site decontamination, sterilization and socket preservation, second stage implant recovery, management of the implantitis, implant osteotomy, and low level laser therapy. Implant, when we apply a diode laser or RBM laser in implant dentistry, it can be from the extraction, it can be started from the extraction till the post-operative, post-rehabilitation time. So it can be an application for faster healing of the extraction, or it can be a decontamination of the extracted site wound before going for a grafting, or it can be an incision placement, or it can be a second stage of opening, as we told. So whatever area you apply as an adjunct, this is going to add to the predictability of your treatment. The implant success rate will be higher when you do an implant surgery as laser assisted or laser integrated. As you all know, the implant soft tissue junction is different from the implant tooth junction. So there won't be much resistance which can be given by the epithelium, junctional epithelium, which is protecting in terms of implant soft tissue junction, where the implant or where the soft tissue and tooth junction, which is protected by connective tissue, is got much better resistance against the intrusion of pathogens. Now we'll come to what does it mean by saying peri-implantitis. It is a inflammation of gum tissue. As you all know about the periodontitis, the peri-implantitis is caused by the same pathogens, and it's an inflammatory response around the implant, including soft tissue and progressive loss of supporting bone beyond the biological bone remodeling. So normally we are expecting a biological remodeling. If it surpasses that biological remodeling process and it is driven by the inflammatory response. It is called the peri-implantitis. In the peri-implantitis stage, the probing depth will be always greater than 4 mm, with bleeding and separation, and radiographic bone loss. What is the biological response to bacteria? The biological response to bacteria is inflammation and bone resorption. So, a continuous inflammation will lead to more bone resorption. Stages of peri-implantitis are mucositis and peri-implantitis. Mucositis is considered the first stage of sequelae of periodontitis or peri-implantitis. Mucositis is soft tissue infection around the abutment or crown implant complex. But the peri-implantitis is an infection around the body or apex of the implant that lead to bone loss. So in the stage of mucositis, it is very easy to control a peri-implant soft tissues to going into the peri-implantitis. So it is important that we should diagnose the situation as early as possible and treat it. Peri-implantitis are classified broadly into early, moderate, and advanced. Early is said to be when periodontal pocket depth is greater or equal to 4 mm. And if the pocket depth is greater or equal to 6 mm, it is considered as moderate. We categorize advanced. Pocket depth is greater and equal 4 mm, but there will be bone loss accompanied by bone loss greater than 50% of implant depth. So early it is greater than 4 mm, but bone loss is very less. Moderate is greater than 6 mm, but bone loss is only 25 to 50%. In advanced case, pocket depth is greater than 4 mm, may not be 6 mm, but the problem is it has got separation as well as severe bone loss of greater than 50% of implant depth. The conventional treatment which is given to the implant, the peri-implantitis, is first we will do the mechanical debridement of all diseased tissues from and around the implant. The tools which is used to debride plastic of Teflon coated instruments, and we may use citric acid or chlorhexidine as an adjunct or tetracycline as an adjunct along with the Teflon plastic instruments or Teflon coated instruments. If we need, we will do bone grafting also. But even after doing this conventional treatment, most of the time, there will be 42% of failures reported according to the literature. So we need some kind of other treatment modalities which increase the predictability in this treatment. That's what this diode laser assisted treatment for peri-implantitis is becoming more important or relevant. In this protocol, first we mechanically debride the implant body with plastic or titanium scaled tip, as we do it in conventional procedures. After that, implant decontamination is photo-assisted decontamination is done by using low-level laser therapy for 60 seconds after placing toluidine glue on contaminated surface. After that, implant is disinfected sterilized by using diode laser. Photosensitizer is a cationic charge, and toluidine blue or methylene blue or polyylysine choline E6 conjugates. These all are used for disinfection of the implant. The infected soft tissue debridement is done with the diode laser. So after taking care of the hard portion of the implant site, we will take care about the infected soft tissue site by doing debridement with diode laser. If needed, bone decortication and graft placement and suture is given in advanced cases. Let us see the erbium laser applications. How the protocol of erbium laser application is different from the diode laser application. In that case, implant is mechanically debrided with the laser. It is not by the plastic curette or Teflon coated curette. Erbium laser itself can directly apply on the implant body because the chromophore of the erbium laser is hydroxyapatite as well as water molecule. The implant body can be easily cleaned with the erbium laser. The implant decontamination after mechanical debridement using erbium laser will give a better implant surface texture for bone attachment. Smear layer as well as biological film is effectively removed from the implant surface, and air water keep the implant cool. So the erbium laser, when you apply erbium laser directly on implant surface, since we have this water as well as air application along with the laser, the implant body will not heat up. Removal of infected tissues, degranulation, and decortication of the bone can be selectively and effectively done by erbium lasers. It's a picture of erbium laser applying on the implant body, the exposed part just before going for grafting that area. The next application is second stage implant recovery. When in the two-stage implant protocol, first we will make the osteotomy site, and on the osteotomy site, you will place your implant and you will suture it. And after 2 or 3 months later, we will go and open it again so that you can see the fixture and connect your healing abutment or abutment to it. The opening of in the second stage might need a second surgical phase with the flap and sutures. When you apply these implants, when you apply this diode laser or erbium laser for second stage opening, you are avoiding a second flap procedure and second suturing on the site. Only thing that you have to care about is implant should not be overheat when you apply laser on it. Upper hand is for the wavelength which has got increased water absorption. So erbium laser has got increased upper hand because it will not heat up your implant body. Diode laser is ideal when the tissue covering the implant is thin. And in case thick fibrous tissue, go with the erbium laser. Because if it is thick fibrous tissue, the chromophores required for diode laser to be act on the site is very less. So ideal thing is going for a erbium laser application. Make sure that tissue is not heated or overheated to prevent recession. And the main thing that you have to taken care of is the attached gingiva serve as a barrier to the implant body. Exposure due to overtime recession is prevented by avoiding the second stage plaque. So you are preserving the quality of the peri-implant soft tissue by avoiding a second intervention. Now we'll come to the another application of socket preservation. So soon after extraction, if you need to preserve the socket by applying graft and membrane. So before going for such a grafting procedure, you have to make sure that the socket is sterile to prevent the infection of the graft itself. So you have to decontaminate. The setting for decontamination of diode with the diode is 0.8 watt continuous wave by using 400 micron tip, and the tip is non-initiated. After that, you can do a low-level laser therapy to reduce the post-operative pain as well as post-operative swelling. In that situation, you should not use any tip. The advantages of using LLLT is reduce pain, post-operative swelling, as well as stimulate fibroblasts in the wound periphery. It stimulates osteoblasts in the socket. So it will lead to a better healing, faster healing, and an uneven foot healing. With erbium, you can do some osseous crest reduction if needed, and gently apply elevator and forceps, debride the socket of tissue or debride the socket, remove lamina dura, de-epithelize, fill the defect with bone putty or bone graft, place horizontal matrix suture, and go with low-level laser therapy with the diode laser. So it's a dual wavelength application. You're using erbium laser for the mechanical debridement and decortication of bone, and after suturing to promote post-operative uneven foot healing and faster healing, you are applying diode laser as a low-level laser therapy. That's the end of today's topic. So we have discussed about the applications of lasers, mainly erbium laser and diode laser in implantology. So we have discussed about the socket preservation and the treatment in the peri-implantitis and implant site decontamination. This all we discussed today. Thank you. We'll see you in the next class.